Thanks, Rebecca, and thanks to the Injury Control Center for giving me this opportunity to speak to you a little bit today around this issue of opioid use, abuse, and overdose. It certainly is an issue with national attention, and I thank you for your presence and obvious interest in this and the impact that you're going to make from your participation in this and from what you learned today in the conference. So thanks for your engagement as well. Certainly, it's a national problem. Drug diversion, the definition of drug diversion is the transfer of a legally prescribed controlled substance from to an individual and its use illegally. Diversion is one of the symptoms that we see from the underlying issue of addiction and what addiction is doing and around the issues of controlled substance and opioid overdose and opioid use and abuse. And certainly, there'll be other speakers that are going to talk about the national impact of this. Michigan is lucky enough or unlucky enough to be one of the states in which we have some of the highest use or highest prescription of controlled substances. You can see the map behind me, that center kind of Ohio Valley and on down to the coast of really the highest states with prescription or prescribed substances, painkiller prescriptions. And there also see some data from a news aggregation service that looked at CDC data and came out with the headlines that Americans are twice as likely to die from prescription drug overdose as they are from handgun homicide. And you can see the graph there on the side. When I was recently in Boston, this was in the paper, in the Boston Globe. This is an open letter from the president of the Massachusetts Medical Society to the state of Massachusetts, and I highlighted some of his comments here because I think as providers, we have a role to play in this as well, and I think as Rebecca alluded to, we're just starting to see where that role comes out. So I'll read this a little bit to you. We recognize that opioid medications may lead some people to addiction. That's why I'm calling on physicians to carefully assess addiction risk before prescribing, then to prescribe the smallest possible dose of pain medications for the shortest time possible. Again, I would echo what Rebecca said. This is a swing in the pendulum from where we were 10, 15 years ago around pain is the fifth vital sign, and that the teaching that we had heard was that legitimately prescribed opioids for acute pain would not lead to addiction, and that it was not at risk. He also says, I'm encouraging patients everywhere to have open, candid conversations with their doctor about opioids. It's okay to ask whether alternatives to opioids would be effective for you. So I think this idea that this is a partnership with our patients around how we're going to manage pain and thinking about managing pain differently, and that opioids is not the only response to pain, certainly is going to be an important part of the conversation. We know that providers and healthcare providers are not immune to abuse. And some basic statistics around that. Food and Drug Administration estimates there's 100,000 people working in hospitals struggling with addiction. And addicts often presume that controlled substances are safer than street drugs. What we're seeing locally, and this was just in our online newspaper this morning, is that as we have tighter controls around prescribed substances, there's increasing uses of heroin. In our county now, and in the town south of us, Saline, Michigan, heroin use and overdose is a significant problem. It's cheaper. It's almost easier to get now as we are doing a better job around controlling or managing controlled substances. So this is where we were at the University of Michigan 2 years ago, and this is why I think Rebecca asked me to speak a little bit about this and what my role in this has been as the interim chief medical officer. So 2 years ago this month, December 2013, we had a nurse that overdosed and died in a bathroom in our old Mott Hospital. And on that same day, the very same day, we had an anesthesia resident who overdosed and was in respiratory arrest in a bathroom adjacent to the PACU. The resident was resuscitated and survived, actually did quite well, is in recovery, and is now working on putting his life back together, and is actually doing quite well in recovery. The nurse obviously died from her overdose. So we had, and then you can see this is an excerpt from our, again, we don't have a real newspaper anymore, but our online newspaper. This is an excerpt from an article from October of 2014 that went back through a number of issues we had around the mismanagement or lack of control around controlled substances. So when we took a hard look at ourselves and said, what is going on at Michigan? What is it that puts us at risk for this? What is it that we need to do to try and address this? We really felt that we had a safety and accountability problem. We had a patient safety and an employee safety problem, and really an accountability problem around how we manage controlled substances. So we had inconsistent compliance with regulatory requirements. Our processes were really designed to favor convenience over control. And that was really operational decisions that had been made over the course of time, that we wanted people to be able to access medications easily and not impair workflow, rather than really address and manage control over those controlled substances. We had lax practices and lax documentation around our management of controlled substances. We had a number of information systems that made controlled substance surveillance very difficult and actually a manual task. We had very poor accountability for when there were discrepancies or challenges around our management of controlled substances. And we had very inconsistent between job families and delayed consequences when there were issues around either discrepancies or true diversion of controlled substances in our organization. And we found that our approach, at least I feel that our approach, primarily around a punitive approach to this, had created a culture that people were reluctant to speak up, and they were concerned about saying anything about someone's management of controlled substances because they were worried that would lead to the loss of their job. And we had someone who lost their life because of that, because people were worried about talking about something that could potentially have consequences of the loss of their job. So we felt that to address this, we really need to take a comprehensive approach and programmatic approach to how we're going to address management of controlled substances in our organization. And that really goes through all these steps, from procurement to security and storage, how we prescribe, preparation, administration, our waste management practices, and again, and suspicious activity monitoring. How do we know that the medication that someone takes out is actually delivered to the patient, and how do we track that over time? And then really, I think the biggest things, and the things that we're talking about today, around education and communication. And in each of these areas, we need very strict controls, rigorous documentation, clear accountability, and meaningful consequences. So just because we're going to have a culture where we want people to be safe to speak up, does not mean that there are not consequences around diversion or opioid use and abuse. And we need to have strong institutional oversight over that project. Things that we've done so far to address this, we did establish a controlled substances oversight committee to get some of this work ongoing, and that group will remain as an oversight group. We're working on medication storage and have improved that significantly across the organization. I think one of the most important things is we really pushed forward with our drug-free workplace policy that really has a couple components to it. We were the only health system in Southeast Michigan that did not have pre-employment drug screening. So that's kind of an intelligence test when you're coming to work in a place and you know that they have pre-employment drug screening, to have that in place. So we established that, and for-cause drug testing in the instances when we have either concern around impairment or concern around just diversion or poor practice around controlled substance management. And then we're also talking about how could we move towards random testing, particularly for those job families that have most ready access to controlled substances. Anesthesia, you'll see, I think, when you talk about this and see what has happened in other organizations. Massachusetts General Hospital just recently completed an investigation by the DEA and have a memorandum of understanding with the DEA around changes they need to make in controlled substance practices. Anesthesia and the access that anesthesiologists and anesthesia work teams have to controlled substances is unique. And we made a lot of progress and have done a lot of work around our anesthesia workflow processes to have better management of controlled substances. We've changed a lot around how we waste and audit and manage our wasting of controlled substances and our scrutiny for discrepancies at our dispensing cabinets, which is the brand Omnicell. I think we've made great progress around our ability to integrate systems and to monitor for what we call suspicious activity. And that is really the ability to look across what's taken out of the cabinet, what's documented as administered to the patient, what's documented as wasted by the provider, and being able to look at all that in a comprehensive way and then compare those providers to like providers and say, are you standard deviation? Are you statistically different than providers like you? And we can look by patient now and say, for all the nurses or providers that have cared for that patient, are you documenting that you're distributing higher doses of narcotics than the others? So we can look at it from a number of ways that's really been effective, and I think will be a leading practice around that. We've changed our access to the OmniCells from having passwords to being BioID login. And really, I think the root of our success is going to be in our ability to develop our pharmacy-based controlled substance management and diversion prevention program. So I'm getting the heads up that we just have a little bit of time left, so I'll move on. Areas in which I think we really have more work to do, and I think we are not necessarily unlike many other health systems in where we were and in where we're trying to get to, are really around accountability and the line of accountability between documentation, performance evaluation, meaningful consequences around management of controlled substances. The biggest issue, I think, is education and communication, and I'll jump to that in just a minute, and then consistent response to possible diversion. So diversion and the management of controlled substances is a multi-victim issue in health systems, and I only think it's going to be when we are able to address a culture where people feel safe to speak up and where people are going to be comfortable in participating in more rigorous management of controlled substances that we are going to make success. So I'm going to finish with a brief video that we've put together around, that I've not put together, the system has put together around controlled substances and addiction, and then I'll leave it at that.
Addiction has been defined as a medical disorder for more than a half century now.
This is an equal opportunity disease.
You can lose everything forever.
I've been working in the mental health field, predominantly in addictions.
I'm a nurse. I've worked in the healthcare system for over 30 years.
I'm a registered nurse in a trauma surgical intensive care unit in Detroit, Michigan.
I've been recovered from alcoholism and drug addiction for 28 years now.
I'm a person in recovery from substance abuse.
I've been in recovery since May 1st, 2011 from alcohol and substance abuse.
I come from a family where both my parents were physicians and struggled with addiction.
I was definitely genetically predisposed to fall into addiction.
We've seen more and more cases that have involved misuse of prescription medications, diversion, meaning taking those medications for personal use.
I began diverting drugs when I was working as a registered nurse in a trauma intensive care unit to bridge the gap from the drug use I was doing outside of work and to keep me from getting sick.
The risk at which this places healthcare professionals is really profound.
Once you begin to use IV drugs, there's no turning back. It's a very slippery slope.
It's as though there's no other way to live other than using a substance.
It can interfere with their practice, with their safety and their ability to practice, can dismantle their personal and their professional lives and lead to complete chaos and dissolution.
I was turned in for diversion by a friend of mine, another male nurse that I was working with, and at the time I wasn't happy, but in hindsight he saved my life. It was, he did me a huge favor. And ultimately I was let go, I was fired. That's the first time reality really punched me in the face and woke me up. It took me two years in recovery to get a position back in a hospital. My life started to come together again, slowly but surely.
I've seen individuals not just be changed and improved, but whose personal lives have been absolutely transformed as a result of their recovery.
If people can begin to speak about it, there's hope. It's when we don't speak about it that there's a lack of hope. It goes underground and is hidden.
We have dedicated our lives and our professions to delivering safe patient care, to enhancing the care of individuals to optimal health. That includes the healthcare professionals who provide those services as well.
So that's an example of the kind of message that we're trying to get out to our organization around what the underlying problem is here, really. So diversion, overdose, drug abuse, those are all the consequences of addiction, and we're going to have to develop better access to and more effective treatments and identification of addiction. So that's why we're here today, is to talk about these issues, to bring these things to light, to learn from each other, and I know that you will do that today, and then also hopefully to facilitate new collaborations so that we continue to improve our ability to understand, to respond, and to make a difference with these issues. So have a great conference, and thank you very much.